I do have some disclosures, which I believe you've already been informed of. And the objectives this morning are, first of all, to discuss the clinical evaluation and treatment of the most common pediatric sleep disorders that you will encounter in clinical practice, and that is behavioral insomnia of childhood and obstructive sleep apnea. Now, of course, this does not at all encompass the universe of pediatric sleep disorders, but given a half an hour of your time, I wanted to concentrate on the things that you're most likely to encounter. I'm also going to talk a little bit about screening for sleep problems in the primary care setting, and my most important task is to keep the audience awake. Okay, so let's start with insomnia of childhood. The clinical definition, the problems that will come to you as presenting complaints are bedtime refusal or resistance, bedtime struggles, delayed sleep onset, which oftentimes accompanies bedtime refusal, but is not necessarily the same thing. You may have a child who goes to bed willingly, but then lies awake for an hour or two trying to fall asleep. Similarly, you can have a child who resists bedtime, but once lights out comes, falls asleep fairly quickly. Prolonged night wakings, or some combination of all three. And typically, these instances require some sort of parental intervention, which is what brings the family into your office with a complaint. We in the sleep world use these definitions from the International Classification of Sleep Disorders, version 2, but I think that they are useful from a primary care perspective as well. So we talk about behavioral insomnia of childhood, and there are two subtypes. One is what we call the sleep onset association subtype, in which falling asleep is often an extended process that requires special conditions, in particular the presence of a parent. And what we call sleep onset associations, these are the conditions that need to exist in order for that child to fall asleep at bedtime, may be highly problematic or demanding, and in the absence of those particular sleep onset associations, the child has difficulty falling asleep. But the most common scenario is that the parent is present at bedtime and willing to do the rocking, the holding, the feeding, the whatever is required to get that child to sleep. So it's not so much bedtime that's the issue, but it's night wakings. What happens is that child has learned to fall asleep with these special conditions. And all of us wake up periodically according to what's called the ultradian rhythm of sleep during the night. It's normal to wake up briefly. Most of us just roll over and go back to sleep. But that child who has only learned to fall asleep with those associations is, guess what, going to need the same conditions present to fall back to sleep during the night. Hence, the problem becomes prolonged night wakings that typically require caregiver intervention in order for the child to fall asleep. This young lady can only fall asleep when the water is on the faucet, and she holds her hand out to feel the water. Mom comes over, turns the faucet out. She awakens immediately, reaches over, turns the faucet back on, holds her hands out, and promptly falls back to sleep. So that's probably the most graphic illustration of a sleep onset association that I personally have ever seen. The other type of behavioral insomnia of childhood is the limit setting subtype. And this is a situation in which the child, typically the complaint is difficulty initiating sleep, and sometimes maintaining sleep as well. But usually the issue is primarily around bedtime struggles. And this is the famous curtain calls. Mom, I need another story. I need another hug. I need to say I love you. I have to tell you something. And there's a long pause while they desperately try to think of something to tell the parent. And this is usually a situation where the caregiver, for whatever reasons, has difficulty setting limits in many spheres around interacting with the child, but it sort of culminates in these bedtime struggles when the parent is tired, really doesn't want to deal with things, and so hence you have this litany of issues. So what is the basic approach? In terms of sleep onset association subtype, you want to establish appropriate sleep onset associations that are going to be readily available to the child during the night. Other interventions are to have a consistent, developmentally appropriate bedtime and bedtime routine. I'm amazed at how many 3-year-olds go to bed at 11 o'clock at night. Transitional objects are wonderful in terms of helping young children to make that transition from wakefulness to sleep. And then I'm going to talk a little bit more in detail about some behavioral interventions. In terms of limit setting, educating and supporting parents about the appropriateness of setting limits. What's appropriate for children at different developmental levels, and getting across the fact that children need limits. They feel safe, they feel not out of control when they have limits set by parents. So again, you need to have a consistent and appropriate bedtime routine. You'll hear this come up over and over again. Clear, concise, and firm bedtime rules that are set not at bedtime when everybody is frenzied and upset and stressed out, but are set when everybody sits down and is calm. It helps to have a graphic representation sometimes of these are the different steps in your bedtime routine, which shouldn't take more than a half hour. This is not a prolonged 2-hour affair, with limited choices. And there's some specific behavioral interventions which I'm going to talk about in a little bit more detail. Now, we're kind of stuck with this psychological term called extinction. But what extinction refers to is eliminating parental attention as something that is reinforcing for undesired behavior, protest behavior, crying, etc. What we call unmodified extinction, or the cry it out, or the cold turkey approach, is basically parents put the child in the room at the designated bedtime and then, short of a nuclear explosion, close that door and ignore crying and protest behavior until the next morning. Now, in the literature, this works really well. But in reality, most parents have a hard time tolerating it. And there may be circumstances, there may be extended family members living in the house, there may be thin walls in which neighbors are calling the social services saying that the child is crying. So for parents who want to do this, it generally takes about 3 days. It works quickly, but again, not always acceptable for families. So we've developed a kinder, gentler form of extinction, if you will, which we call graduated extinction, or sleep training, or the checking method, or the Ferber method, after my colleague Dick Ferber. And these are a variety of different variations on a theme in which parents ignore bedtime crying, but for specified periods of time, not just closing the door and leaving. So what this involves is a gradual shaping of appropriate behaviors and then fading of the intervention so that the child learns to fall asleep independently. So graduate extinction typically involves putting the child to sleep drowsy but awake, and this is probably one of the most important pieces of anticipatory guidance that you can give at the 4-month visit, is to tell parents to start putting their baby down drowsy but awake, so that they learn to fall asleep independently. If that is indeed a culturally appropriate goal for that family, and then you avoid all of these problems. You can use a fixed or progressively longer interval. It really doesn't matter. There's no magic number, but you can do 2 minutes, then 4 minutes, then 8 minutes, or you can do 5-minute intervals. It really depends on the parent's tolerance for the protest behavior. Minimize the interactions during check-ins. So you don't want to pick the child up, make it playtime, make it reinforcing. You want the interaction to be brief and boring. It's time to go to sleep. Mommy's here. Everything is good. Good night. Generally, we suggest that they use the checking method at bedtime only and continue to do whatever they've been doing for night wakings, because once that child has learned to fall asleep independently at bedtime, that will generalize to night wakings. And there are many different variations on a theme. Sometimes we have the parent stay in the room with the child and then gradually move the chair that they're sitting in further and further away. Sometimes we have the child actually come into the parent's room on a separate sleeping space, like an air mattress. So there's lots of different ways to kind of modify this general schema. Pitfalls, okay? First of all, the extinction burst. Things are going to get worse. The child is going to protest harder, cry louder, God forbid, make themselves throw up before things get better. And if you don't warn parents about this, that this may happen second, third night, they will be cursing you in the middle of the night saying this has only made things worse. So you have to help them understand that that's going to happen. You also want to avoid the intermittent reinforcement or lottery theory. Here's a scenario. Child comes into the parent's bedroom, parent dutifully returns the child to bed, first 3 or 4 times. It's 3 o'clock in the morning. Child comes into the parent's bedroom again. Parent says, oh, I got to get up at 6. I have a big meeting tomorrow. The hell with it. Just get into bed with me. What that teaches the child is if I persist long enough, I'll get what I want. So it's actually more difficult to extinguish an intermittent reinforcement paradigm than if you just let the child come into bed every time. And once parents understand that, I think that's very helpful. You want to optimize the timing of the intervention. Don't do this when you have your in-laws coming to visit or you have a big project at work. Pick a time, because this is going to be stressful for families. Pick a time when you're really sort of psychologically and emotionally ready to do this. Don't allow the child to sleep in the morning. You want to increase their readiness for sleep the next night. And generally, you'll see improvement in a week if the parents are consistent. And both parents have to be on board with this. You can't have a good cop, bad cop kind of scenario. Bedtime fading is helpful oftentimes for limit-setting behavioral insomnia. And this is temporarily delaying the bedtime closer to the time that the child is actually falling asleep. So you increase their readiness for sleep. It eliminates a lot of the stress and angst that is going on. And sometimes these kids actually have a little bit of a circadian issue going on, and they're not ready to fall asleep until 8:30 or 9 o'clock. But then you can keep the wake time constant and gradually move the bedtime back by 15-minute increments until you reach the actual bedtime goal. So the idea here is you're matching the child's bedtime with his or her natural sleep onset time, and you're decreasing psychological and physiologic arousal that often accompanies these bedtime struggles. Positive reinforcement, what did we do before the golden age of stickers? I don't know, but kids will do almost anything for a sticker. And so the carrot part of things is also very important to incentivize children to stay in bed. And you want to set the goal at a level where the child can be successful, but not so low that they're successful all the time or so high that they can't really achieve it. And then you can up the ante as time goes on until you reach your eventual ultimate goal. The bedtime pass is kind of like a little get-out-of-jail-free card. It's really nice for anxious kids. You give them a little cardboard pass at lights out, and they can get up out of bed once. But if they get up, they have to hand the pass in. And for many anxious children, they don't even bother. They don't bother getting up. But the idea that they have this, they have the opportunity to get up out of bed, is very reassuring for them, and that can work quite well. And then, if all else fails, this apparently was the hot Father's Day gift this year. I went to a Borders bookstore, and there wasn't a single copy left. So obviously, we've struck a nerve. Okay, we're going to shift gears here and talk about sleep-disordered breathing. I'm going to go through this really quickly. The spectrum of obstructive sleep disordered breathing in children ranges from primary snoring, which by definition has no ventilatory abnormalities, to, on the other side of the coin, apneas, which is a complete cessation of airflow for at least the duration of 2 baseline breaths, and the most common pattern of sleep disordered breathing in children, which are hypopneas, which is a 50% or reduction in airflow that's associated with desaturation and an arousal or an awakening. And just a reminder that central apneas involve that cessation of airflow without respiratory effort, while obstructive events have continued respiratory effort. Nocturnal symptoms of obstructive sleep apnea syndrome: loud snoring, frequent snoring, respiratory pauses, increased respiratory effort and paradoxical movement of the chest and abdomen, restless sleep, sweating during sleep. These kids have really increased work of breathing, so they're restless, sweaty sleepers. They may sleep with their neck hyperextended in order to increase the upper airway diameter. There tends to be a higher incidence of secondary enuresis in these children, probably due to the disruption of the normal secretion of antidiuretic hormone. You may see an increase in partial arousal parasomnias like sleepwalking and sleep terrors, and oftentimes parents are quite anxious about their child's respiratory status during the night. Daytime symptoms can include mouth breathing, chronic congestion, hyponasal speech, frequent morning headaches, which may be a reflection of CO2 retention, poor appetite, growth failure. And the daytime symptoms which have gotten a lot of press recently are the mood, behavioral, and cognitive changes that oftentimes accompany sleep disordered breathing in children. So we don't see as much in the way of excessive daytime sleepiness, although that tends to be more common in obese children with OSA. But we oftentimes see mood instability, externalizing behaviors, hyperactivity, aggressive behavior, oppositional behavior, internalizing behaviors like social withdrawal, and ADHD-like symptoms. So never diagnose a child with ADHD without asking about sleep, and particularly potential symptoms of sleep disordered breathing. If you don't remember anything else I've said this morning, please take that home with you. You may see learning problems in these children, and of course, as a result of all of these, academic failures. There aren't a whole lot of clues on physical exam, but you may see increased or decreased growth percentiles. More common these days, obesity in these children, very important risk factor. You can see increases in systemic blood pressure. You may see signs of atopy, mouth breathing. A quick and dirty little screen for hyponasality is to have the child repeat a phrase with consonants, Mickey Mouse, my name is money, with their nose unoccluded and occluded. And if they sound pretty much the same, then they probably have fairly significant either adenoidal hypertrophy or other forms of nasal occlusion. You may see adenoidal facies, airway crowding. Tonsillar hypertrophy is common but doesn't necessarily correlate with the degree of obstruction. This is just a visual picture of mouth breathing, different degrees of mouth breathing. And this is the Brayette scale for tonsillar size, ranging from 0 to 4+ or kissing tonsils. This is obviously crowded pharynx, and this is what's called the Malampati classification, which is generally used in adults, but I think is helpful in appreciating the size of the upper airway and the likelihood of obstruction. Pediatric polysomnography. I'm going to spend a bit of time talking about this because I think there's some important new recommendations in regards to respiratory indications for PSG in children. These were published by the American Academy of Sleep Medicine in March of 2011. So the recommendations are: PSG is indicated when the clinical assessment suggests the diagnosis of OSA in children. In other words, clinical evaluation, history, physical, audio-visual recordings do not have sufficient sensitivity and specificity to establish the diagnosis. And you should have a combination of those clinical factors and PSG results in order to make the diagnosis. It's also indicated in children being considered for TNA to treat OSA. Children with severe OSA have an increased risk of postoperative complications, and clinical parameters are unreliable, not only for diagnosing OSA, but also for predicting severity. There are certain high-risk conditions, such as obesity, Prader-Willi, cerebral palsy, craniofacial anomalies, in which the clinician should consider PSG in children if there's even the slightest suspicion of sleep-disordered breathing. Intermediate risk conditions include a history of prematurity, African American race, a family history of sleep-disordered breathing, systemic hypertension, and these ought to be carefully questioned for signs and symptoms and should undergo PSG if present. PSG is also indicated in the following respiratory disorders: chronic asthma, CF, pulmonary hypertension, BPD, only if there is a clinical suspicion for accompanying sleep-disordered breathing. Children with mild obstructive sleep apnea preoperatively should have a clinical evaluation following TNA to assess for residual symptoms, and if these are present, a sleep study should be performed. Sleep study is also indicated following TNA to assess for residual OSA in children who have moderate to severe disease preoperatively, who are obese, who have craniofacial abnormalities, and have certain neurological disorders that increase the risk of sleep-disordered breathing. PSG is indicated for positive airway pressure titration, both initially and in follow-up, certainly when the clinical assessment suggests sleep-related hypoventilation resulting from neuromuscular chest wall deformities, but children who are treated with supplemental oxygen do not routinely require overnight PSG for oxygen therapy management. PSG is indicated when there's clinical evidence of a sleep-related breathing disorder in infants who have experienced an ALTI. And the reasons that it's not routinely indicated is PSG does not assess for altered cardiovascular control, and the bottom line, it's not predictive of recurrence of acute life-threatening events. PSG is indicated in selected cases of primary sleep apnea, and because most of these infants are diagnosed by clinical history and observation alone, and only should be used when other medical disorders have been ruled out. I'm going to skip over, because we're running out of time, adenotonsillectomy. Just know that this is now the second most common ambulatory surgery in the United States, and sleep-disordered breathing is now the primary indication for adenotonsillectomy in children. However, less than 10% currently of children undergo preoperative sleep studies, and even fewer postoperative. So there's a huge potential there, given these new recommendations for preoperative PSG. Other treatments, weight loss, of course, more difficult, easily said than done. There are some studies looking at oromandibular retaining devices. There's some new data that suggests that nasal steroids and leukotriene esterase inhibitors, particularly in combination, may be helpful in children with borderline to mild sleep-disordered breathing. And of course, avoidance of environmental triggers, which may exacerbate allergies. I'll just leave you quickly with what we call the BEAR sleep screen, which is a 5-question screening device that we have looked at in primary care settings, and I think identifies more sleep issues than just simply asking, how is your child's sleep? Bedtime problems. Does your child have difficulty falling asleep or going to bed? Does your child seem sleepy or overtired during the day? Does your child wake up at night? How frequently? For how long? What time does your child go to bed and get up on weekdays and weekends? How long does your child typically sleep? And does your child snore? And of course, in older children, you need to ask them as well as parents. I'm not going to go over these algorithms. Hopefully you have a copy of those in your handouts. But these are just some ways of kind of going through in a systematic way once you've identified a sleep complaint. And other tools that you have at your disposal, there are a number of good sleep questionnaires out there. Sleep diaries can be extremely helpful in teasing out what happens on a night-to-night basis. If you have a child in whom you suspect sleep terrors versus nocturnal seizures, having the parents videotape this at home and bringing it in can be very helpful because these are often sporadic events. The overnight sleep study indications we've talked about. The multiple sleep latency test is primarily to look for narcolepsy or other forms of excessive daytime sleepiness. And actigraphy is a wristwatch-like device that is worn at home and approximates sleep and wake patterns, and I think is becoming more of a clinical tool.